Okay, folks, so we're going to talk about patient assessment, and this is chapter 9 of your book, the EMT basic book. I'm using the patient assessment lecture slides from chapter 10 of the advanced book because that's all I had access to today. So I'll use your own slides, but they're pretty much the same. So never fear. And here we go. Okay, our patient assessment is the bread and butter of what we do. It's how we identify issues, it's how we gather information, it's how we form a plan of assessment and are able to carry those things out. We perform 5 sections in the patient assessment, which we will go over individually. And the key here, I think, is to remain organized. And so we have skill sheets that we are going to hand out to you that has a step-by-step process. It's a linear process that we have to teach you. And honestly, in the field, carrying out these steps on patients, it is super important to remain to just be organized, do it the same way every time, and then you don't miss steps. So that's what I found in my career that helps me. So this next slide is kind of a flow chart of how this goes. But the first step is our scene size up, which we perform on every single call to keep us safe, to keep everybody safe. Our second section is our primary assessment, and that is performed the same way on every single patient. If you miss steps, so if you just willy-nilly go through a primary assessment, you could potentially miss a life threat and that patient could die because of your negligence. The next part is basically our fact finding, our focused history and physical exam. And I divide this in, your book doesn't do this very well, but I divide this into a focused history and physical exam or a rapid assessment, which we will talk about in a bit. But if the patient is able to talk to you and give you information, then it's obviously going to be a focused history and physical exam with vitals and getting their chief complaint and all that sort of stuff. If our patient is altered in any way or unresponsive, or we're unable to kind of ascertain what's going on because they're not speaking to us well, then we're going to perform a rapid trauma assessment. That's a 60 to 90 second assessment, head to toe survey, so that we kind of are gathering information in that quick assessment so that we could figure out kind of what's going on. The next part is a more detailed or a secondary assessment. And this, again, this will be a head to toe, more methodical, very detailed assessment, checking, really minute things in different areas of our anatomy. If we haven't started to gather vitals, we're going to gather vitals at that time, get more of a sample history, and all that. And then our last part is our reassessment survey. And our reassessment survey is performed every 5 to 15 minutes, depending on the stability of our patient. So if we have a very unstable patient, we're going to perform that reassessment survey every 5 minutes. And if we have a very stable patient, we can wait for 15 minutes or so to totally reassess. And basically what we're reassessing is our primary assessment, our level of consciousness, any of the interventions that we've performed, and figuring out if what we're doing is working or not. So we're going to go in detail in every section. Okay, so this is that flow chart that I said I'd show you. I'm gonna, and this is just to help you kind of get your head around this. So the first section right here is our scene size up. And like I said, we do this same scene size up on every single call. The second section here is our primary assessment. In our primary assessment, and I can't stress this enough, you do and perform the same way in every single patient. Okay, so we're going to talk about that. And then we kind of branch off. We can either do focus history and physical exam, or we could do a rapid assessment depending on how our patient has presented. Again, if the patient is able to speak and give us a chief complaint, why they called EMS today, what is the main complaint that they're worried about today, then we can do a focus history and we can ask patients, say they're having chest pain, we'll ask chest pain questions and we'll go further into detail on their chest pain and some respiratory issues and stuff. Whereas if our patient isn't really talking to us or is very confused, it's very difficult to say, oh, well, I need to do a focus history on this cardiac patient when you haven't been told it because they can't speak to you. So that is why we do a rapid trauma assessment and kind of gather the information quickly in that 60 to 90-second exam, and basically figure out if there's life threats, if there's anything I need to assess further, and then we go into our vitals and our blood glucose tests and all of that. Next part here is our focused history, or our secondary assessment, sorry. Our secondary assessment is more methodical, very detailed, where we check things like the sclera in our eyes and the conjunctiva, and if I have fluid in my nares and all that sort of stuff. So we just go in detail in every single body part. And the last part here is our reassessment survey. And that is performed either every 5 minutes or every 15 minutes, depending on the stability. Okay, we're still going through some of our competencies or objectives, but when we talk about the scene size up, we're going to talk about safety of the scene, and if it's not safe, we need to either make it safe or call people who can make it safe. So we're gonna look at things in the environment, that cold, humidity, ice, rain, those kind of things that will affect our patients. We're addressing hazards, road hazards, fire hazards, electrical downed lines, all of those things, any potential violence from either the patient or the crowd or bystanders or whomever, whether we need to figure out, call in different specialized resources, so different help like a hazmat team or maybe some river rescue team or something like that. And then we were going to talk about standard precautions and personal protective equipment and what to do in multiple patient situations. When we're going through our patient assessments, both medical patients and trauma patients, the same components or things that we do are the same for both types of patients. Our primary assessment is a very good example of this. We always perform our primary assessment the same way. We're going to check level of consciousness, the airway, the breathing, the circulation. We're going to make sure that there's no massive hemorrhage going on, and we're going to form a general impression. So we're going to do that stuff every single time, and we will figure out if there's life threats in that primary assessment that we need to address. Anything concerning airway, breathing, or circulation or perfusion is a life threat, and if we identify something, we need to fix it. Okay, so the part of history taking where we determine the chief complaint, the mechanism of injury or the nature of illness depending on medical or trauma patient, any associated signs and symptoms, we'll talk about what those mean, and past medical history, medications, pertinent negatives, all of those things are what we're looking for in the history. The secondary assessment is the full body scan, and helps us to find some of the little things that we haven't found yet in the focused history. It's where we take our vitals, any of our pulse oximetry, blood glucose monitoring, all of those things, along with the assessment of the vitals, the blood pressure, the respiratory rate, the pulse rate, temperature, and skin signs, pupils, those kind of things. We're also going to go into how to assess patients with complaints of respiratory compromise. We're going to teach you how to assess lung sounds, breath sounds, and what they're supposed to sound like, and what are some of the sounds that you hear that are not normal. We're going to assess the cardiovascular system, other things that we assess when we're assessing the cardiovascular system, like any edema in their legs or jugular venous distension, any edema in their jugular vein there. We're going to talk about a neurological exam, how to assess for strokes quickly and do a fast exam. We're also going to try to figure out with musculoskeletal is also part of a neurological, where we assess pulse, motor, and sensory in extremities, and then basically just how to assess all the parts of our bodies. I don't really have to say much about assessing blood pressure, pulse oximetry, and blood glucose because we just talked about it in the former slide. Okay, reassessment survey is reassessing our primary assessment, all of our interventions, our vital signs, making sure that if there's any changes, we document those, and then we will do our assessment for unstable patients every 5 minutes and for stable patients every 15 minutes. Okay, let me introduce what signs and symptoms are. A sign is an objective thing that you either see or measure, or something that is measurable, like a blood pressure, like pupillary response, because you know the size of that. And we will look at signs when we're doing our patient assessment, as well as symptoms. And symptoms are something that the patient tells you. It's a subjective thing that the patient feels. So it's not something that we measure at all. It is something that is subjective in nature and what is told to you. A chief complaint is the reason that EMS was called. So what is the thing that's bothering them the most right now? And it could be something like chest pain, or it could be that I, twisted my ankle when I stepped off the curb or something. So now when we are caring for patients, we do what is called critical decision making and critical thinking. And this is more than just following a protocol, or if I have this situation, this is what I do. This is something that we do, and you will get better and better at it as you go on in your careers and as you see more patients and treat more people. But what we're doing is we're using patient assessment skills. We're gathering all the information that we can. We're evaluating that information and trying to decide based on the signs and symptoms and all of the past medical history and everything, chief complaint that they've been complaining of. We evaluate all that information. We put it all together and we try to form what we call differential diagnosis. Now, there's many differential diagnoses for the same signs and symptoms sometimes, and that's good. Like, there are many causes to altered mental status, not just that their glucose is low, or, there's many reasons, and we gather information and do all these measurements of blood pressure, SpO2, all that, to take that stuff and to kind of work out a plan in how to treat and intervene with that patient. So the synthesizing, so we gather information, we evaluate that information, we synthesize that information. This is how we kind of articulate our assessment. We devise a plan of interventions and we carry those out. And then we document that stuff. And then we basically have to be able to defend our treatments and our interventions that we do based on the information that we gathered. So that that critical decision making and that critical thinking is super important. And as we go on in our progress through our class, we'll share, Michelle and I will share information or scenarios or something that you could go down one pathway if you don't ask certain questions, or you could, get off track if you don't perform a complete assessment. That's the reason we do that, is so that it drives home the fact that we have to perform very solid patient assessments. We have to rely on our knowledge of pathophysiology and how our bodies work, and all the blood pressure measurements and all that sort of stuff that we put together and we gather. We put it together and then we decide what's going on and we intervene and hopefully are able to mitigate or stop a situation based on our, treatments. So that's the purpose of talking about critical decision making. That's what we do. Okay, so let's talk about the scene size up. And this is where you evaluate the conditions that you'll be working in, whether it be inside someone's house or outside on the street or road or highway or in a field or whatever the situation is. You're gathering that information so that you can assess whether that scene is safe for you to enter. And when you first arrive on scene and start paying attention to that stuff, that is called situational awareness. And situational awareness is something that is changing all the time. It's a dynamic thing. So scene safety can be fine one time and not the other. So what I try to say is to keep your head on a swivel, to continuously assess people around you, the situation, move your eyes, move your head, because it's really easy to just focus in on where you're going. So you have to pay attention to everything else. You have to consider road and traffic hazards. If you are on a roadway or a freeway or a highway or something, you need to wear the high visibility safety vests that the American National Standards Institute, or ANSI, that is a requirement that you have those so that people can see you, you can see others. So unstable, ice, unstable situation, roads, violence, chemicals, hazmat stuff, all that sort of stuff. We need to keep looking for, and also know that anything that, like, if you have a jacket on and gloves and a hat because it's really cold and wintry outside, your patient's going to be needing the same stuff, and if they don't have it, then you're going to have to get them out of the elements quickly. Okay, so that is what you'll start with your scene size up. Also, dispatch gives you information. We can't only rely on that information, but we can start thinking about safety. Do we need police officers there? Do we need high angle rescue, or do we need more fire apparatus? Do we need a hazmat team? All those things you start thinking about at the time of dispatch. All right, this is just a picture of the high-vis vest and the need for looking out for hazards. And um, that's a lot of metal and sharp stuff that's going to be that you're going to be working around. So just protect yourself, the patient. If you go into an enclosed car to help the patient with extrication and stuff, and you have a helmet on, then you probably should get a helmet on your patient too, so that they're protected as well. So just remember those things. Okay, so determining mechanism of injury or nature of illness. Mechanism of injury is the forces or the energy, um, how they fell, what they fell on, how the patient became injured, and that helps you kind of focus in on um, discovering what injuries you're predicting to happen and the places where we need to look. Um, Also, remember the forces applied to the body. Um, that kinetic energy doesn't just go away once it hits one thing. That, if you fall down, your body hits the surface, and then your organs hit as well inside. So don't forget that. So good understanding of the anatomy and physiology of our body systems and how we're put together helps kind of help you figure out that trauma that could be there. The nature of illness basically is for medical um, patients what they're complaining of, um, and likely be the things that you're assessing for, like a chest pain patient or a respiratory patient or a diabetic patient. All right, so sometimes people are not just one or the other. Sometimes a medical issue caused the traumatic injury. Um, so, like a seizure causing a fall, causing a head injury kind of thing. So, um, don't get focused in on one. Keep your mind open and your options open so you can determine with more information what's going on. This is just talking about blunt force trauma and penetrating trauma. Um, Blunt force trauma can happen over a broad area. The skin's usually not broken. It's maybe a contused or abrased, but always consider the underlying organs and tissue and bone and all that sort of stuff while you're assessing them. Penetrating trauma, point of impact between the skin and an object, usually has an open, obviously, wound. There could be other wounds, say it's shrapnel from a blast injury. You need to check for many things, penetrating trauma and blunt force trauma. This is just talking about the nature of illness and asking the patient or bystanders or the family or the officer who greets you or whomever is there. Just say, hey, what seems to be the problem? And if the patient's talking to you, ask them what seems to be bothering them today. Okay, taking standard precautions. This is a method that we take, and what we do is we assume that all body fluids are dangerous, they're infectious. So we protect ourselves from that. Um, we wear gloves at a minimum to protect ourselves from any infectious diseases or anything getting on our hands. Um, Things like masks and eyewear, goggles help us keep from becoming, uh, I guess, infected from our patients. But also things like turnout gear, helmets, um, thick gloves if we're doing a lot around metal and sharp things. So those are the things that we need to be thinking of before we get to the patient. Don your personal protective equipment. put on your gloves. I put my gloves on as as I'm exiting the ambulance before I even get to the patient, because if you don't, you're going to have to possibly intervene quickly and touch them without protection on. Another part of our scene size up is determining the number of patients. So we need to know if we need additional resources, ambulances, if we need more help. If we have too many patients that then we can handle, then that's going to be a mass casualty incident. We're going to need to call in reinforcements and establish incident command. We will discuss that mass casualty stuff, triage and incident command later, but we need to know the number of patients. And then considering any additional or specialized resources that we need to call in. Do we need more ambulance? Do we need a helicopter? Do we need a chemical hazmat team? Do we need law enforcement? Do we need a power company to come turn off the power? So all those things we need to consider. Okay, so we just talked about our scene size up. And now and we do the scene size up on every single call. This is the next survey that we do, and that's the primary survey or primary assessment. And the goal of our primary assessment is to identify any life threats and to begin treating and fixing those things that we can that are deemed life threats. We, again, do this primary assessment on every single patient the same way. Okay, this isn't an entire head-to-toe survey yet. This is just a quick check of their LOC, their airway, breathing, circulation, disability, and exposure, basically, and identifying life threats and fixing them. Life threats are things like massive hemorrhage or a hole in the chest or someone's airway is closed. We need to suction someone's airway to clear it. Those kind of things are what we're identifying in our primary survey. Okay, so the first thing we do in our primary survey is form a general impression. And this is as we're walking up to the patient, we note how they are. We note if they're leaning forward, not looking at you. Does the patient appear to be unresponsive? Do they look hurt, or does this look like a medical issue? Do we know at all? Did they acknowledge your existence as you walk up? You look at their age and their sex and the color, this is all before you even basically touch them. So that's our first part. And then based on a little bit, before we even get a lot of information, that general impression, we can kind of have a high index of suspicion for major problems or life threats, and then treat them. Okay, after we've formed our general impression, we assess the ABCs. And the first thing we do is airway assessment. So always start with your airway. Is it open or patent? Is it maintainable? Is the patient able to keep his airway open? In responsive patients who are talking to you, they're moving air. And what you're going to know is if you hear any signs of stridor, and stridor is a high-pitched kind of a squeal or a squeak when there's a partial airway obstruction, maybe due to swelling, maybe due to a foreign body being in there. That's an upper airway issue. So we're kind of just figuring out the airway. If their airway is blocked by maybe vomit or blood, we've got to position them and suction them to clear it. If they're not moving any air at all, do they need the Heimlich maneuver? Do we need to do abdominal thrusts? Is If they're unresponsive, we open their airway. And if it's a trauma situation, we open it using a jaw thrust maneuver. If it is a medical issue, it's okay just to do a head tilt chin lift. Okay, so that's what we do. We look in their mouth a little bit if they're unresponsive. We see if it needs to be suctioned, if their teeth are intact. So that is our airway assessment. Okay, this is showing you in our unresponsive patients the jaw thrust maneuver. And I'll show you how to do that in our practical portion of this lecture. But when we are unresponsive, there is the opportunity for our tongue just to kind of relax and fall back into the back of our throats and kind of block our airway. Also, things like vomit and blood and food and all that sort of stuff can obstruct our airway. Okay, so the second part is the B, or the breathing. Now, this is separate from the airway. Airway has to be open, clear, and adequate and maintainable. But the breathing needs to be present. And a patient who is breathing without our assistance is spontaneously breathing. And we need to ensure that that breathing is adequate. Okay. Do they appear to be choking? Are they moving some air but not enough? Are they breathing too fast or too slow? Are the patient's respirations really shallow or very small in tidal volume? Or are they really, really deep, large tidal volumes? Do they appear cyanotic or blue? Usually when someone is not breathing adequately, they have some cyanosis or some blue hints of um, blue, like around their lips and on their fingertips, fingernails, and their earlobes and their nose seems to be a little bit more blue. Do you hear weird movement of air? Like, can you hear from the doorway that they sounds like they're breathing through water, you know? Or, so that's what we kind of are doing, where we want to know our breathing rate. Is it too fast, too slow? And is it adequate? Is it too shallow or just absent? You know. Now, a complete um, breath includes inspiration and the expiration. So inhaling and exhaling. So what we want to do is quickly check a rate. And I'm not counting like 12 times a minute or 18 times a minute. I want to know, is it normal, fast, or slow? This is still our primary assessment. How about the depth? Is it too shallow or is it normal? Do I have a good chest rise on both sides, or is just one side of the chest going up and down? That's the thing. Those are the things that you assess when you're assessing breathing. If they're complaining of difficulty breathing, or they have a complaint of a respiratory issue, I auscultate breath sounds at this point quickly. And I'm not doing it, you know, really in detail. I just want to know if they're there at this time and if I hear some weird noises quickly. I will do a better breath sound assessment after the primary assessment, but only if they're complaining of breathing difficulty, and that's when I assess in the primary assessment. Otherwise, I will do it a little bit more detailed in a bit. Look at how much effort it takes them to breathe. Are they using muscles that we don't normally use to breathe? That's called accessory muscle use. Are they positioned in a tripod position, meaning leaning forward, usually with their elbows or their hands on their knees, and they're leaning forward? That's called tripod position. Does it look like it's labored breathing? Does it look like it's distressing to breathe? And that's what we want to know. Now, we're going to put on a pulse oximetry. And again, I have a partner. I can have them, I can just say to them, will you get me a set of vitals right now? You know, in my primary assessment, as I'm assessing the primary assessment, they're doing vitals. I'm not stopping my primary assessment to do vitals. I'm just doing two things at once. And this is what happens once you become pretty good at assessing patients. You have your partner doing one thing while you're doing another. And this primary assessment has to be completed. So I'm going to complete it, okay? But I can have them put on a pulse oximeter on their finger, and while that's, you know, getting a reading, I can continue on in my assessment. Good oxygen saturations, just as an aside right now, are between 94 and 99, 100%. On room air, most people at this, you know, at this altitude are 94, 95%. If they have some sort of lung issue or COPD condition or something like that, they might need supplemental oxygen to keep their oxygen saturations from becoming too low, and we'll discuss that more later. Now this is showing you the tripod positioning. This kiddo over here on the right is tripoding. He's leaning forward. He's got his hands, you know, so he's kind of increasing the diameter of his chest by leaning forward and holding himself up that way. Sniffing position is, you know, when you sniff, you kind of move your head forward. That's sniffing position. That's getting your airways all lined up. So that's called sniffing position. Those are two common positions for someone who is having difficulty breathing or labored breathing. Okay, the next part after airway breathing is circulation, and there's three parts to circulation checking. So I'm going to check a pulse is one. I'm also going to check for massive hemorrhage. I'm just going to put bleeding. And then the next one and the final one is to check their skin signs. So when I say check circulation, we mean all three of these. So we're going to check our pulse, whether it's too fast, too slow, and adequate, whether there's massive bleeding. If there is massive bleeding, we're going to stop it, and our skin signs. So whether they're different colors than what we normally are, which is pink, warm, and dry. Okay, so what a pulse assessment is that pressure wave when that ventricle contracts. You can feel that next to an artery that's fairly close to the surface. And so normally we check a radial pulse and or a carotid pulse in somebody who does not have a radial pulse. And I'll show you that in a minute. The next slide is a picture of that. Okay. So when I come upon a patient who is conscious, as I'm doing that primary assessment, as I start to talk to them, my fingers just very easily and naturally go and feel their radial pulse before, you know, I say to my partner anything, you know, let's put on some oxygen or anything like that. I'm just trying to get a feel for their pulse rate. Now, experienced providers, and you'll get better at this as well, are doing that primary assessment pretty much simultaneously, all those steps. So they're looking at the patient, getting their general impression. They're looking at their airway and making sure it is open and clear. And if they're talking, it's you know, they're moving air. They're assessing their breathing, whether it's too fast, too slow, or labored. And then they're checking a pulse, and they're doing all that very rapidly. So you can do a primary assessment in under 15 seconds easily. But on this pulse rate, what I want to do is if I feel a radial pulse, I'm going to just quickly assess whether it's a normal rate and the character is good, strong, you know, all that, or if it's too fast or too slow. And a weak or thready pulse is a pulse wave that's coming through an artery that has constricted or gone to a less diameter. And we do that when we start to go into shock. So I want to assess whether I feel it regularly strong or thready or very bounding, like when you're running and you stop to check your pulse rate, you know, how it's just like boom, boom, like you can see your pulse, um, you know, in your wrist and all that. That's a bounding pulse. Assessing pulse rates or assessing pulses in kids younger than 1 year, we're going to use their brachial pulse right there because um, their necks are so squatty and little. It's really hard to check a carotid. A brachial pulse is adequate. If someone doesn't have a pulse, what do we do? Start CPR. Yes, that's what we do. Um, And if they're not breathing and we've started to give them rescue breaths, and they do have a pulse, we just continue to give them rescue breaths, just like we learned in CPR. So not difficult at all. Okay, assessing skin signs. So adequate perfusion or the circulation of blood and oxygen to where it needs to go and taking out the bad stuff. That's perfusion. This needs to happen all the time. So assessing skin color helps us assess how well they're perfusing or getting blood and oxygen where they need to go. So skin signs are color, temp, and condition. Okay, so color, we're normally pink. If you're a dark pigmented person, like a black person, it's really hard to check um, paleness based on just looking at their face. So what we do is we check their conjunctiva, or this is the inner lining of your eyelid, and we just kind of look at pull their eyelid down just a little bit and look to see if that's pink. It should be pink and moist. That's normal. So that's what we're doing when we're assessing skin color. We're looking at their skin signs. Now this is showing you inadequate perfusion. So um, peripheral circulation, like I said, we can see that perfusion adequacy in their skin signs. This kiddo has cyanosis. He's got that bluish gray color on his face, and I suspect if you could see his hands or his fingers, you'll see it there too. Um, that's not good. We need to fix that. You can also be a different color like yellow from liver disease or jaundice, that's called. Um, there's a mottled color that is you'll notice that, but it's a gray and blue blotchy kind of color, and that's really bad perfusion. Um, so that's not a good thing. Now, skin temperature, we should be fairly good temperature. We shouldn't be too hot or too cold. And this clammy thing is having sticky and cold skin signs, and that happens when we're going into shock. So we're normally pink, warm, and dry. And so skin temperature, you're either too hot or too cold, and that can be an indication of shock or hypoperfusion. Hypo meaning less, perfusion is that circulation stuff going on. Skin condition or moisture, we are normally fairly dry. Not super, super dry, not super, super wet. But if I'm just sitting in my front room and it's a normal temperature outside and it's not 100 degrees in my house, I shouldn't be dripping sweat. That can be an indication of some disease processes going on, some shunting of or vasoconstriction of our vessels. So we shouldn't be too wet. Now, if I've just ran, if I'm in physical education, if I'm in PE class and I twisted my ankle, do you think I might be sweaty because I've just been running? Yeah, so you have to take this moisture thing in context, I guess it would be. Okay, capillary refill time, or CRT. This is a good assessment to check for circulation adequacy distally, in their periphery, hands, feet. So what we do is we squeeze their fingernail, we compress it and blanch it out and then let go, and 2 seconds or less, that should be pink again. So in the time that it takes for you to say capillary refill, it should be pink. Now, older adults that have circulation issues and stuff in their hands and feet, it might not be an adequate or good assessment to do, but you can still check it. If you're cold, what happens to your capillary refill? Yeah, it gets delayed. So you've got to take the assessment findings that you have into context, just like I said about our skin signs. If you're exercising, you're going to be sweaty probably. Okay. All right. And the last part, or third part of this circulation assessment, is to assess for and control any major external bleeding. Now, when you take a pre-hospital trauma life support class or some sort of tactical medicine class, you're going to find that they teach you to assess for major bleeding and fix it first before your airway assessment. And that is great. If you see some artery that's spurting blood when you first come upon a scene, what are you going to do? You're going to stop it. You're going to put your hand on it and try to compress it. You're not, waiting to do that until you've assessed their airway and breathing. You're doing all that sort of stuff at the same time. So it's okay to think about your ABCs, but this massive external bleeding should probably have been addressed as soon as you found it. So what we're going to do is identify and control any major external bleeding, and then stop it. We're going to put direct pressure with our gloved hand on and get some bandaging to control that bleeding. If there is no pulse, we're going to start CPR, and that makes sense, right? Oops. Now, this assess for disability and the next exposure. In your primary assessment, as soon as I've checked my general impression, my airway, their level of consciousness, their airway, breathing, circulation, I've got enough information based on that and their Glasgow Coma Scale to prioritize my patient into, hey, this is an unstable patient, I need to move, I need to get to the hospital quickly, or this is okay, we're gonna just stay and play, is what we say. We can spend some more time on scene. We don't have to quickly load the patient and start towards the hospital yet. So this disability and exposure part, we do as soon as we've made our priority patient decision, we're going to assess for disability. So we're going to do a quick neurological exam, and basically this will be getting a little bit more into their level of consciousness, whether they are unresponsive, responsive but confused or altered level of consciousness, responsive with an unaltered level of consciousness. That means that they are speaking to you and making sense. Okay, so that's part of their level of consciousness check. They have a normal mental status. Now, something that we need to think of are possible spinal cord injuries with our trauma patients, and that's part of a disability assessment. So the things that we're going to do, because we need to stabilize their spine and their neck and hold it in a neutral position early on in our assessment so that we don't make their spinal cord injury worse. So things that we're going to look for quickly are the mechanism of injury. If we think that that's indicative of a spinal cord injury, any pain or tenderness in their neck and spine, just if they're saying, ow, 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 my neck hurts and I can't move it, whether they can't move at all, they're paralyzed. Priapism is an erection in a man or a boy that shouldn't be there at that time. So that could be indicative of a spinal cord injury. If they're altered because of a trauma incident, it could increase our suspicion of a spinal cord injury. And if they're having difficulty speaking because of maybe of a head injury or something like that. Now, a quick assessment of someone's level of consciousness, we can go by the AVPU scale: alert, spontaneously, or alert to verbal commands, or alert to painful stimulus, or plain unresponsive. So that's the AVPU. These mnemonics, or little hints and things that we kind of use all the time in medicine, they're going to help you figure out what people are talking about. And so these are things that you're going to start to memorize, okay? So AVPU is one of those things. Now, orientation, whether they're able to answer your questions appropriately. That's what their orientation is. The most common ways we check that is to check the orientation if they can answer 4 simple questions. And it's called being oriented times 4. So person, place, time, and event. So do they know who they are? Do they know where they are? Do they know the day? And do they know what happened? So the person, place, time, and event. That's oriented times 4. If they're oriented times 3, we need to know what's off. Do they not remember the event? Okay, and so forth. Glasgow Coma Scale is a scale that is in your book there. That is a point value scored for eye-opening, verbal response, and motor response. And we'll go over this in more detail later. But basically, you score these 3 responses and you get a cumulative score. And you rate that score. If it's a 15, because you can get, it's from the lowest score that you can get in a category is 1. So you can be dead and have a Glasgow Coma score of 3. The best score that you have, add up all those numbers there, are 15. So if someone is alert and oriented times 4, they're appropriately responding to you and all those questions are answered. Their eye-opening is spontaneous. Their verbal response, they're very oriented and can answer your questions appropriately, and they're following your commands, motor response, they get a 15. Now this is showing you some places where we can assess for a painful response. And our point is not to inflict as much pain as we can on someone, but is to see how they respond to that painful response. Whether it be they posture, and we'll talk about posturing in our Glasgow Coma scale, but whether they flex their arms or extend their arms, whether they're just flaccid and don't move at all, those are our concerns. So the first one, A, there he's showing you pinching their earlobe. B, they're putting pressure right there on that, above that bony orbit right there. C, I do a trap squeeze instead of a neck squeeze. I just squeeze someone's trap. Another thing you can do is put the knuckles of your hand on someone's sternum and kind of just put pressure down on it. It's called a sternal rub. So all of those, what you're doing is assessing their response to that painful stimuli. Now we need to expose someone's injuries or check to see if there's injuries underlying those clothes and stuff. But again, realize that if it's cold, we need to expose and then cover them back up so that they stay warm, okay? And that's just part of assessing your patient. Now this next part right here, they are saying to perform a rapid full body scan. Now, the way that I teach it, if you saw in that first flowchart thing, if your patient is talking to you and able to respond appropriately, I can do a focused history and physical exam and ask them questions and examine, the systems and the body parts that are affected that they're complaining about. If somebody is not responsive or is altered and unable to answer your questions, I'm going to have to do this full body assessment or rapid exam or assessment. And that's a quick head to toe palpation, inspection, and listening or auscultation from head to toe. It's done in 60 to 90 seconds. We use this mnemonic called DCAP BTLS to help us remember what we're assessing when we're looking at that body part. And it stands for, which it will show you in a minute, deformities, contusions, abrasions, penetrations, punctures, burns, tenderness, lacerations, swelling. So you are going to say that 100,000 times in this class. You're going to be able to say it quickly and without thinking about it. So you're going to have to practice this. And once you be able to say deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling, that fast, every single time. Okay? So that's our goal. All right, so this is, I've got enough information to gather to treat life threats. So airway obstruction, respiratory arrest or failure, anybody in cardiac arrest, severe bleeding, those things, big giant holes in your chest, those things are life threats and I need to fix them. All right, determining our priority and transport decision. So high priority patients or patients that need to be transported quickly to the hospital, we don't stay on scene very long with them. We try to fix their life threats, start our treatments and get going and continue our treatments in route. But if somebody has a traumatic injury and needs spinal immobilization or spinal restriction precautions is what we call them now, we take the time to properly package them so that we don't aggravate or injure more someone's spinal cord injury. Now, long ago, they coined this thing called the golden hour, and they found that with trauma patients, they fared better if they were transported quickly to the hospital and in a surgery suite within an hour so that a surgeon could fix the things that we can't fix, inside. So we want to spend a minimum amount of time on scene when someone has sustained a significant trauma. So what that means is we have to identify quickly, perform our scene size up, our primary assessment. We do a rapid, what I call rapid trauma assessment. We package them on our spine board and move them to our stretcher properly, and we'll teach you how to do that, and get them in the ambulance, and then the rest of our assessment of vitals, all that sort of stuff is done en route. Our treatments, all the things that we need to do that haven't been life threats, like opening someone's airway or something like that, are done en route. That's called rapid transport. And we want to keep our scene time in that golden hour to about 10 minutes. So we've got to really identify and move and do things not just fast, but rapidly with a purpose and safely. Okay? So that's called the platinum 10 minutes. We want to get there, start assessments, start interventions, package them, get them en route to the surgery center so that they can be properly cared for. Okay, we're going to talk about the important part of a patient assessment called history taking. And this history is going to help us identify um, signs and symptoms that they're feeling and what you see based on their chief complaint. How did this start? You know, what do they think precipitated these events? Did it come on suddenly? How does it feel? Do you have any other problems? All those things we gather in the history taking process. We gather as much information as we can from the patient. If the patient is unable to kind of identify what's going on, whether they're confused or they just don't understand, have, you know, learning disabilities or they've got Alzheimer's or something like that, then we're going to have to ask those folks around them, care providers if they're in a facility, or their spouse, their family, anybody that was with the patient. We also identify things like medical alert tags, and especially if the patient is unable to communicate with us. And then once the call has finished and we're handing the patient off and all that sort of stuff, we have to document all that stuff. We have to document information to give to the hospital as well, so that when we leave, they have written documentation of what we gathered, what we found. Sometimes just leaving a scribbled piece of paper because you didn't ever have time to write everything down in the proper place on your patient care form will help them immensely. If you have the time, or if you are able to, if you write things down on your PCR, it's usually a triplicated form. You give one part to the hospital, you keep one, and you give one to the first responders that were helping you, because they have to document things as well. Things that need to go on there especially are times of your interventions and what those interventions were. So when you put on oxygen and how much, if you gave aspirin and how much, if you gave nitroglycerin and how much, all those things are very important. So times of medication administration, or if you had applied a splint and that you had, pulse motor and sensory before the splint application and after the splint application. These things are all very important to document. Things that are important to remember when you're gathering a history is just simply start by introducing yourself. Hey, my name is Jody Zufelt, and I'm a paramedic, and is it okay if I ask you some questions and treat you? And usually they say yeah, and also get down at their level. You don't want to tower over them, and while you're speaking to them, that's, communication that's not stated. That's saying I'm more important than you. I'm the authoritative figure here, so hear me roar, kind of thing. That's not how we want to be. We want to get on their level. We want to take our sunglasses off. That is a super disrespectful thing to do, to talk to someone with sunglasses on. My eyeglasses, transform from dark to light and light to dark based on the sun outside and all. If those haven't changed fast enough, I will even put them up on my head when I'm starting to talk to someone if I come from outside to in, because it's important that they see my eyes and I make eye contact. And speaking compassionately and listening is a huge part of communication. Sometimes we have to keep them on track because they're wandering as we ask questions, and that's okay. It doesn't mean you interrupt them and, cut them off. It just means that you direct it back. And this stuff is all called therapeutic communication, and it's part of what you're going to be learning as you're taking care of different patients. But some things are very important. Being respectful, being compassionate, getting on their level, making eye contact, listening to their answers. You're going to find yourself initially at, in your mind, you're asking 14 different questions, as they're answering the first one that you asked, and therefore you kind of didn't pay attention to what they said, but you have your second and third question already in queue. So I'm just letting you know that you need to actually listen to what they said. And if you miss something because somebody said something to you or something like that, just say, "Oh, I'm sorry. I missed what you just said. Can you repeat that?" You know, we're all adults. We all want to be treated with respect, and I expect you to do that. Um, so that is the first part of history taking. Okay, now investigating that chief complaint. This is the chief complaint is the answer that they gave to you when you said, "What seems to be the problem today?" Whether that be chest pain or shortness of breath or I twisted my ankle, whatever that is their chief complaint. And now you get to investigate, how did this happen? Did it come on suddenly? And again, eye contact, body positioning, therapeutic communication, being compassionate, not overbearing, listening. All those things are very, very important. If um, someone has given you a patient report, like the first responders that got there before you, you need to be respectful to them as well. And just think, that golden rule, do unto others. You're going to give a patient handoff report to those in the ER, and it is very disrespectful when they interrupt you, when they just don't listen, when they could care less what you say. And if we do the same thing to those folks that are giving us a patient report when we first get there, we're just doing exactly how we don't want to be treated. So be respectful. Um, and the patients are going to be telling us how they feel. Um, and those things are called symptoms. We can't directly observe nausea. We directly observe vomiting. So the difference between those two things, one is a symptom because they feel it, i.e. the nausea, and one is a sign. It's something that we can observe, that we can touch or feel. So those are the different things that you're trying to investigate. The signs and symptoms that the patient has. Symptoms, again, are things that they feel. So if they feel short of breath, we can observe respiratory difficulty and difficulty with using accessory muscles or breathing rapidly, or you can hear wheezing and that sort of thing. Those are signs. But we can't measure or observe someone who says, "I feel short of breath," or "I'm nauseous," or "I have tingling in my hand." Those are symptoms. So that's the difference between the two. Okay, investigating the history of present illness. This again is based off their chief complaint. How did this start, kind of thing. So a good mnemonic that you can use for many medical and some traumatic stuff that we need to know is the OPQRST, and I put a U at the end as well, and I will explain that. So this is trying to gather the circumstances that happened around what their complaint is. And some of the most important circumstances, we can use this mnemonic to help us figure this out. So onset, when did this start happening? Did it come on suddenly? Did it come on gradually over days? When did you notice the problem beginning? What were you doing at the time? So there's it's important to note things like exertion, or I'm having chest pain. It started when I was shoveling snow from the driveway, or I'm having chest pain. It started while I was sitting on the couch watching, um, CSI or something. So that's important to note. So onset, O, onset. Provocation and palliation, the P. So provoke, how was, did anything bring this on? Provoking factors. What were you doing when this started? Palliating factors are things that bring relief. So did it stop or lessen when you sat down um, and rested? Those kind of things. So provocation are, like say a chest pain patient. Um, Again, what were you doing when this came on would be a question for provocation. I was riding my bicycle up a hill when my chest pain started, or I was sitting here just twiddling my thumbs. So those are two um, things: the onset, provocation, and palliation. And again, I want to stress the importance of being present as you're communicating with someone. That means listening and making the eye contact and trying to make sure that you're letting them know that you're listening. Okay, the next letter in the OPQRSTU mnemonic is quality. Now, this is the description from the patient of the whatever is going on. So try really hard to not lead them with your question like, is this a sharp pain? So just ask, um, what does the pain feel like? And if they kind of look at you like, what? Then you can give more identifying stuff like, does it feel sharp, or is it a heavy pressure, or those kind of questions. So patient's description of the pain, um, try to avoid leading them with that, and then have patience with how they answer you, because um, it might take them a while to describe the pain or the medical issue to you. And then location. Can you point specifically to where it hurts, or is it just a general area? So that's important as well. Um, so that's quality. Okay, OPQR. So let's talk about the R. Now this is region and radiation. So the region is, where is it hurting? And radiation can be pain that is from one, so say it started in my chest and now it's moving to my left arm and my jaw. So that is radiating pain. It's a trail of pain to a different part of the body. Now, referred pain is pain that exists in more than one place without that line or trail in between. So I'm having chest pain, but I'm also noticing I have pain in my right lower quadrant in my abdomen. That there's not necessarily a line of pain there, like a radiating pain from a chest into the left arm, where they actually kind of, when they describe it, usually they'll like say, yeah, it's radiating down. So that's region and radiation. The OPQRS, severity or scale, is their perception of how bad this is. This, I like to say, I'm going to give you a scale and I'm going to qualify. So I'll say 0 means no pain at all, 10 being the worst pain that you can imagine is that scale or severity. And um, and that's a subjective thing. Some people minimize their pain and some people can't, very well, don't take pain very well at all. So they might have a hangnail and they could say that's the worst pain they've ever felt. So it is a very subjective thing. Now, things that are not as scale related, like say they're short of breath, and you ask, how severe is this attack? That is a severity thing. And they could say, um, this is the worst attack I've ever had with shortness of breath. Of course, they're not going to say it like that because they're going to be sucking down wind trying to breathe. But you can say, is this the worst attack you've had, or is this seems to be not the worst attack? You know, have you had worse? So how bad is that compared to previous ones? Um, Something that you can ask is, what happened last time you had this happen? You know, um, and 0 to 10 is that scale. Um, and the last one here that they have is timing. Timing. This will be, you know, help me pinpoint when this started. So it's 8:15 now. When did this start? So did it start 20 minutes ago when you called? Did it start 14 hours ago? And it just got worse. That kind of helps you as well. Now let me talk to you about the U, since we're going down the alphabet. And I teach this, and it's kind of, you know, just my own thing. There's the U. These are utter things. Okay, I grew up on a ranch. I milked cows. So these are utter things that I need to ask. So say with chest pain, and these are almost kind of pertinent negatives, things that I want to know are present that I would probably find in most patients having chest pain. Pertinent negatives are things that you suspect are going on at the same time. So I'm having chest pain. Are you short of breath? Are you nauseous? Did you break out in a sweat? Diaphoresis. So these are other things that I need to ask that you expect to have happened because they're having cardiac chest pain. Other things. So shortness of breath, nausea, vomiting, dizziness. Um, did they break out in a sweat? The diaphoresis. Do they have jugular venous distension in their neck because they have increased central thoracic pressure? Do they have pedal edema in their legs because they have congestive heart failure? These kind of things are the other things that I need to ask about, pertinent negatives and things that I expect to find. And interventions, things that they've done prior to calling 911 that they've medicated themselves with. Say they were having pain and they took a hydrocodone, or they are having chest pain and they took 4 aspirin. Those kind of things you need to ask so that you know what's already been done, so that you don't overdose them on something that you're going to do. And then, like I said, my other things that we talk about are identifying pertinent negatives. And these are expected findings that you would suspect are there or should be there based on their complaint, but things that may not be. And I just put it under the U so that I don't forget to ask all those other questions. All right, so OPQRSTU. This is kind of investigating that history of present illness. This is history taking. It's a very important part of what we do. Now, some patients are not going to be able to talk to you in complete sentences if they're having respiratory difficulty or enough pain that they can't, you know, talk very well. So with respiratory patients that are having severe pain, you're going to have to ask yes and no questions, and maybe say, I don't want you to speak much. I want you to shake your head. Okay, so that's important because they're going to get out of breath and make their situation worse. So please keep that in mind as well. In addition to using the mnemonic OPQRSTU to help us in our history taking. We use another very important mnemonic called the sample mnemonic. And this is just, again, to help us remember the questions that are important. So, sample is signs and symptoms. Again, this is the things that they're answering your questions, the things that you're identifying and seeing. Allergies. Do they have any allergies to medications? Do they have any environmental allergies? Um, are they allergic to penicillin? Are they allergic to aspirin? Those kind of things. Medications. This is their medications that they take. It is very important to get a very good list of the medications that they have. If they don't have a list written down, if you ask, where are your medications, so that I can have somebody start writing those down, that's important. Also, the P is pertinent past medical history. This is, do you have any high blood pressure? Do you have high cholesterol? Have you had a heart attack before? Do you have diabetes? All those medical issues that they could have, they need to tell you that. So, do you have congestive heart failure? Um, are you receiving care um, from a doctor for any medical issues? Now, it's important to sometimes catch yourself. Sometimes I'll ask, do you have high blood pressure? And they're like, no, but I can clearly see in their medication list that they're taking antihypertensive medications. Well, they don't have high blood pressure right now because they're taking their medications as prescribed. So I look and I go, oh, are you taking medications for high blood pressure? Then they say yes. So sometimes I get caught saying that. Their last oral intake. This is important. If they are going to have surgery, then we need to know when did they drink and eat something last, or is something causing their abdominal issues because they just ate and then they started, so that's important for that too. And then events leading up to the illness or injury, and you usually gather this when you're asking, your OPQRSTU questions. But this is just the last part of our sample. What were you doing when this happened? Um, and all those OPQRST helps you figure that answer out as well. So OPQRSTU and sample history taking. Okay, part of history taking is sometimes gathering information on sensitive issues. Some of those are alcohol and drug use, physical abuse, sexual history, being sexually active, having, sexually transmitted infections, and um, physical limitations, those that can't, mentally comprehend what you're saying, Alzheimer's patients, um, physical and mental challenged folks, people with massive anxiety. Those kind of things can be sometimes very difficult. So sometimes you just have to ask questions, and you have to ask the parents or the caregivers or something. The patients aren't, maybe able to give you any history or anything. Those that are under the influence of alcohol and drugs may be hiding things. What they tell you may not be accurate, and it might compound what's going on right now. Having a chemical dependency, they may be very, not forthcoming with what they tell you. And so ensuring that you have a good rapport, ensuring that they understand that you're not a police officer and that what they tell you is kept under confidence. And just ask things like, do you take medications for chronic pain? Do you drink every day? have you been treated for a alcohol or chemical dependence before? So there are ways to ask carefully, and you will probably feel a little nervous, until you get used to it. But therapeutic communication, having a good rapport, respecting your patients, all those things play into that. We have to, by law, report physical abuse for children and the elderly. If law enforcement is on scene and they've told you they suspect this is an abusive situation, then it's already done. If later on you start suspecting that this is a child abuse situation or elderly abuse situation, as you ruminate and as you think on the situation, then I think you have 72 hours from the time that you start suspecting to get a hold of Department of Child Services or vulnerable adults. And there is a form and a link on the Idaho EMS website. So I'll try to remember to find that for you. Okay, sexual history. It's really difficult for, adolescents to talk about their sexual history in front of their parents. So sometimes it's important to kind of separate them when you're asking those sensitive topics. Honestly, any female having abdominal pain, one of those differential diagnoses that you have are pregnancy issues. So are they having an ectopic pregnancy? Are they bleeding excessively from something? Those kind of things. So sometimes we just assume and ask questions. When was your last menstrual cycle? It is difficult, I understand, for male patients to ask these, but it's part of gathering a history. So you just have to get over it and do it. Okay. Sometimes we have challenges when we are trying to obtain a history with those that are not communicative with us, those that are not answering our questions. Look for cues around the house. Are they deaf? And there's usually some sort of special, equipment that they have or things that they use to help them with blind patients and deaf patients and that sort of thing. So look for those things. If they're silent and not talking to you, maybe the rapport that you start gathering or obtaining, I guess, will overcome that, and maybe they will talk to you. Sometimes just asking simple yes and no questions at the beginning helps them to open up. Maybe your partner has a better rapport for some reason. Maybe they've connected with them, and so maybe they can start asking questions. So there's all kinds of ways to overcome some of these challenges. And on the other hand, maybe the patient is overly talkative. Maybe they've taken some, stimulant or are unable to focus. Maybe they're having a psychotic episode. All those things make gathering what's going on right now sometimes very difficult. But sometimes if you just focus them a little bit, you're able to kind of direct that conversation. As well as those folks that have multiple symptoms going on. Maybe they use the ER as their primary care physician, and they've been sitting on a lot of issues over the last year or two, and they have a lot going on. Just be patient. We realize that this is not a good use of the ER facilities to use it as their private medical thing, but that's the way our healthcare right now is. So we just have to be patient and spend a little extra time, as well as the elderly. They have a lot going on sometimes, and they tend to sometimes bring it all up at once, and just be patient. It's our job to gather information. Maybe somebody has excessive anxiety. There's a lot of conditions that can cause an anxious feeling. Think about those with respiratory issues and their brain is hypoxic. They might be very anxious. Hold a pillow over your face for a while and not be able to breathe and see how anxious you get. Um, Maybe it is an anxiety or panic attack that they're feeling, or the symptoms that they're explaining there, like chest pain and things, are caused from their anxiety. And maybe it's the chest pain causing the anxiety because, again, they're, having a big issue. Maybe their sugar is low. What you need to understand is, if you've never had a panic attack or felt the anxiety, or maybe it's a medical condition, you have to treat them respectfully. Be patient. Be confident in what you're doing. Try to get them to calm down. Don't be demeaning in how you're talking to them. Every patient encounter can lead to violence and anger. So, from the patient, from the bystanders, from the parents, from whomever is there. So, you being calm, um, observant, again, keep your head on that swivel, like I've said in the past, and look for nonverbal cues. Are they making a fist in their hand, and is their voice getting tense and terse? And if you need to leave because it is not safe, then leave. Don't ever stay in a situation trying to diffuse it if it has become um, over the top. We don't want to be caught in, a hostile situation. Intoxicated patients. So sometimes it's very difficult to gather information, like I've said, with intoxicated patients. And don't assume that just because they are under the influence of alcohol, the symptoms or whatever they're feeling is due to that. Or sometimes, hypoglycemic patients or patients with low blood sugar can act like they're drunk. So there's a lot of things that we need to consider when we think that somebody is under the influence of alcohol. Be non-judgmental, be accepting, be compassionate, and patient. Somebody who is crying or feeling an emotional surge, it's okay. At least they're breathing. So be patient, soft in your approach, respectful. Understand depression. It can be very debilitating. Those that haven't experienced that, you don't understand. So, depression is a very normal response to things, and some people have depression and have periods of low lows, and that's just something that we have to deal with. Again, be empathetic, be compassionate, be patient, be respectful, listen. Okay. Okay. Someone who is rather confused or just altered, we call that alteration of awareness. Um, we need to find their baseline. So maybe they have some sort of underlying medical issue, like they've had a stroke before and they have Alzheimer's or dementia or something. We have to find their baseline from caregivers, from folks that deal with them on a daily basis. And there are many things, like I've said, strokes, low blood sugar, diabetes, trauma, hypoxia, medications that can cause confusion. So we have to assume that their confusion is not normal until we know what their normal baseline is, and until we've ruled out things that we can fix, like low blood sugar, low oxygen levels, and that sort of thing. those with limited cognitive abilities. So folks that are unable to um, express themselves, that have limited um, men mental capabilities, we need to involve the caregivers, the family, those that are taking care of them, and don't treat them like they're dumb. Again, compassion, patience, respect go a long way. All right, language barriers. Be aware that there are a lot of non-English speaking patients that we have the pleasure of dealing with, and maybe there's somebody there that can interpret for us in the house. Um, there are apps, Google Translate I use sometimes. Sometimes there are um, numbers that we can call to use a medical translator. Um, just maybe being respectful, compassionate, trying to be patient in this encounter. That's most of the time when I haven't been able to gather a lot of information is because of language barriers. So use the resources that you have. Sometimes if you can call a relative or something and have them help you translate, be great. Hearing impairments, we kind of talked a little bit about those that are deaf. Just go slowly, use your resources. Um, Maybe they can read lips. Don't yell at them, um, and just be patient again. Blind, visually impaired, just be aware that, there's just like hearing impaired, there's different degrees. So visual impairments and hearing impairments can be total or could be on a scale. Um, Visual impairments, just remember to identify yourself, make sure that you talk and tell them what you're going to do. It's important when you're gonna check their vitals and stuff that you tell them that you're gonna do that, and doing an EKG that you're going to be what you're going to be doing. So just explain things carefully. Okay, now let's go on to the secondary assessment. And this is a very detailed exam that looks at every part of the body. This is when we take all of our vital signs, including um, blood glucometry, so sugar levels, pulse oximetry, um, all of the normal blood pressure, pulse, respiration, skin signs, level of consciousness, orientation questions we're going to ask now, pupils, the size, whether they're reacting, whether they're equal. So that's what the secondary assessment is, a detailed assessment. This is done after you've already performed your scene size up, your primary assessment. If there's a need to do a rapid assessment, we've done that 60 to 90 second head to toe. This is done in conjunction or after you're kind of finding the focus history and physical exam questions and doing all the chief complaint questions and stuff. Okay, so that's what we're going to do. Okay, so pulse oximetry, just so that you guys get a quick rundown of this stuff. It monitors the gas saturation of hemoglobin, not only oxygen, but carbon dioxide, carbon monoxide, meth, carbon hemoglobin, all of those gases that attach to hemoglobin. It's gonna be able to measure the saturation. Now, just a regular pulse oximeter does not differentiate between those gases. You have to have other oximeters or other probes to check other gases, but it will give you false high readings or low readings based on the saturation concentration of whatever is hanging onto that hemoglobin. Okay, so if I have somebody that is a carbon monoxide patient, that carbon monoxide has a higher affinity or attachment liking to the hemoglobin than oxygen does. So it kicks off the oxygen and the carbon monoxide attaches. Well, when my pulse oximeter gets on there, it just reads that that hemoglobin is fully saturated. It doesn't know that it's carbon monoxide. So also anemic patients that have low iron, the levels of hemoglobin are decreased, and so they may have all the hemoglobin that they have might have be fully saturated, but say they only have 60% of what they should have because they're anemic, they still could be hypoxic, you know. So people that are in shock with low perfusion levels or cold hands, anything like that, those levels are not going to be very accurate usually. So it is useful, but you need to understand that there are problems with using that pulse oximeter. You have to use your assessment skills as well, so that you're not getting information that isn't correct and taking that as it is. So, okay, this is just explaining to you what I just said, so we'll just keep going. Okay, blood pressure measurements, non-invasive blood pressure. This is your blood pressure cuff, and there are auscultation methods, palpation methods, and electronic or oscillometric. That's your automatic blood pressure cuffs. I've said before when we were talking about patient assessment before that you should have at least one auscultated manual blood pressure in your patient so that you can kind of assess whether your electronic measurement is correct. Palpation is not as accurate. Sometimes in high noise environments where you can't auscultate correctly, we get a palpated blood pressure, and I've showed you how to do that, where you assess the radial pulse, keep your fingers on it, increase that blood pressure cuff where you would, and let it go down slowly as you watch that gauge. The first palpated, or when you feel the first radial pulse, is that systolic. You will not get a diastolic range. So just understand that electronic devices or the automatic blood pressure cuffs, they are prone to have their readings are not accurate. So that's why we check. Just a quick, another vital that we could be measuring, especially paramedics in advance, when we place an advanced airway in, such as an endotracheal tube or a supraglottic airway, is end-tidal carbon dioxide. I also tend to want to know my end-tidal carbon dioxide levels of patients who are having difficulty breathing or patients who are altered in any way, and I'm kind of just assessing the amount of cellular metabolism that is happening. As you know, we need to stay in homeostasis, so we need to cellular metabolism happens, and everything happens to keep us in a steady state or homeostasis. The amount of oxygen that we intake helps with our cellular metabolism, with aerobic metabolism. Well, a byproduct of normal cellular metabolism is carbon dioxide. So in a normal person, our end tidal should be between 35 and 45 millimeters of mercury. And if it is increased or decreased in any way, it helps us realize how their body is functioning, whether it be a shock environment or a respiratory problem. We kind of measure that. Now, we have capnography on our LifePak 12s, Zoll monitors, the LifePak 12s, the 15s. So it's a normal measurement that we can take when we insert an airway just from our ECG monitors. And that capnography gives us a number, which is a capnometry number, as well as a graph or capnograph. So capnography is the graph that you'll see, the waveform itself, which tells us some things when they exhale. And it's just a measurement of their exhaled carbon dioxide levels. Okay, we're going to teach you how to use a glucometer, and the blood glucometer measures the glucose levels in the bloodstream. And there are capillary and venous specimens that we can use. A capillary specimen would be poking someone's finger, and a venous specimen would be using like an IV needle that your advanced or your paramedic has just used to insert an IV, and then you take a drop of blood off of that sample. And we'll teach you how to do both of those. And just know that there's a slight difference between a capillary and a venous specimen. However, it's usually very negligible, so it's not something that you're going to get like an erroneous high or erroneous low. And the glucometer needs to be calibrated, and you do that using some reagent solution based on that glucometer. The test strips that you use need to be the ones that are for that device and for that batch, and that they are not expired. So all those things matter. Okay, we have discussed the use of a full body exam, or what I call that rapid assessment. This is when somebody has significant mechanism of injury, who is unresponsive, or who has a very critical condition, or are kind of like not speaking to you much about what's wrong. This is that quick 60 to 90 second full head to toe using DCAT BTLS, and basically inspecting and palpating quickly, finding hidden injuries that are going to possibly be aggravated before I move the patient. So on those folks that we've decided to use that, it is done quickly. Now, we've kind of discussed this focus assessment. Those folks that have no significant mechanism, they're able to speak with you normally, they're not confused. Those folks, you can ask their chief complaint, ask them what's going on, and all the OP, QRST, all the sample history, but you are going to have to touch and palpate and auscultate and do things based on their chief complaint. So if they're complaining of abdominal pain, you're going to have to assess their abdomen. I kind of keep this in mind when I'm assessing specific kind of organs, that our systems are connected. Our cardiovascular system is very connected to our respiratory system, and our abdomen, we can have abdominal pain and have a cardiac issue or an aortic aneurysm, where we're going to find problems with the heart and cardiovascular system, but the pain is appreciated in our abdomen. So I kind of remember when they have a general complaint of, say, abdominal pain, I look at the systems above and below that area. So when I palpate and auscultate, not only just the abdominal section, but I'm also um, focusing my assessment on the chest and the GIGU, or gastrointestinal gastrourinary systems. Everything is connected, and that's kind of what my goal is to make sure I don't miss anything. So this is something that's done slowly and methodically. Okay, now we're going to kind of take our main body systems and just discuss what we are looking for, what we're assessing. So respiratory system, you obviously are going to be looking at the chest, exposing their chest, looking for symmetrical rise and fall of the chest. When one side of the chest goes up, opposite of the other could mean a few things. It's called paradoxical motion, and we'll get into that as we assess more injuries and trauma and stuff. We're going to listen and auscultate breath sounds. You can sometimes hear things like stridor, which is an upper airway obstruction that we've kind of talked about before. It's a high-pitched like that, that you're going to hear from their upper airway. You're going to auscultate their lung sounds and listen for any wheezing, any crackles. So wheezing is a kind of a high-pitched whistle that you're going to note, usually on expiration, but it can be on inspiration and expiration. Crackles is a fluid, crackly sound that you're going to hear when there's fluid in the lungs. It sounds kind of like if you take your hair by your ear and crinkle it in your fingers, that crackly sound that you hear, that is what crackle sounds like. You're going to look at the respiratory rate, measure that, measure the quality, whether it looks labored, whether they have accessory muscle use. So if they're using their neck muscles and their abdominal muscles and their intercostal muscles to help them breathe, that's because they're breathing. It's hard for them to breathe, and that's labored breathing. That's accessory muscle use. Look at their positioning, if they're tripoding. All those things we're going to look at in their respiratory assessment, as well as the rhythm of their respirations. If it's irregular, if it is a pattern. So where do you auscultate lung sounds? I told you in the rapid assessment, we're just going to do kind of a quick assessment, high and wet, listen to the whole lung in and out, just for presence. When you're doing more of a detailed or a secondary exam, we're going to listen in more lung fields. We're going to listen carefully in our upper lung fields, just right below the clavicles. We're going to listen lower, almost nipple line over to the side there in your anterior or mid-axillary area. If you don't know where that is, look in the body systems chapter and remember where your axilla is and where the middle of that, or whether the anterior part or more forward part, where that is. So about 1 inch below the clavicle, in the middle of the clavicle, so mid-clavicular line, lower lungs by the mid-axillary line, down lower. Lift the clothing so it is easier to auscultate directly on the skin, and push firmly. So on the posterior back, it's easier to listen if they're sitting up because you don't have as much tissue as you do from the front, especially with females who have breasts. So that you want to assess whether they have a cough, whether they're spitting out yellow, green sputum, brown, all that, whether they have pink frothy sputum. All those things we're going to be assessing. the depth of their breathing as well, whether it's very, very deep or very, very shallow. If it is shallow and their tidal volume is decreased, we need to assist them in their breathing. This is reminding you that normal respirations should be at a rate of about 12 to 20 breaths a minute. And it is important to actually count their respirations. It's really easy to do a fast count, like if they're breathing very fast. So if they're breathing about once every 2 seconds, that'll be 30 times a minute, and that's pretty fast. So there has to be a reason why. And then we talked about respiratory rhythm, whether it's regular or irregular, has a pattern. This is talking about, like I said, the quality of breathing. Can you hear good air movement in and out, or is it decreased or not even there? Do you see the rise and fall of their chest? Stridor, that upper obstruction, either by swelling or by a foreign body or something that you hear. The bubbling or gurgling or the crackles, fluid in the air, in the lower airways. This is showing you a picture of where to auscultate. So this picture right here is showing you about an inch below the clavicle, and that's mid-clavicular right there. So if I was going to assess mid-axillary, I would assess about right here. Of course, not on his arm, but that'll get his lower fields. Now, this is also showing you on the posterior. You can remember that your lungs are pretty high. So when you're trying to auscultate, you're auscultating around the scapula. So the scapula is like right here, or a little bit farther there. And so if I listen here and here and here, those areas right there on the posterior are good areas to listen to. You can also listen right here in the posterior axillary area. Breath sound should be nice and clear, no adventitious or extra sounds should you hear. So those sounds that you hear, the wheezing, the crackles, the rhonchi is, of course, like when you have bronchitis and you're coughing up crap, that rhonchi is in the upper, the big airways there in your bronchi. And then the stridor we've talked about a little bit. Now, pleural friction rub is just the two linings of your thoracic cavity, the visceral pleura and the parietal pleura. If they become irritated, maybe lose some of that pleural fluid, they'll rub a little bit, and it sounds kind of like if you've ever sat in a saddle in that leather, and you hear that leather, that moving, when you're moving, you hear that creaking. It kind of sounds like that sound. Depth of breathing is a measurement of the amount of air that the patient is breathing in and out. That tidal volume, normal adults breathe between 300 and 500 milliliters of air every inspiration and exhalation. So if it's way too shallow, we need to assist them. So that decreased tidal volume, we need to assist them and help them with a bag valve mask and ventilate them. So, and somebody can have an increased tidal volume, as in when you're running or exercising, you'll increase your oxygen demand, and therefore your respiratory rate and your tidal volume will increase, trying to get the oxygen, where it needs to go now that your demand is increased. You have a table for normal respiratory ranges for adults and teenagers, school-age children, preschool, toddlers, and infants. Just know that anybody that breathes less than 12 times a minute in an adult, well, anyone, is decreased in their rate. And anybody that's breathing, even infants, over 60 times a minute is way too fast. You can't really get a good depth if you're, as an adult, if you're breathing 30, 40 times a minute, you're not really able to get a lot of air because you're just taking another breath as you're taking in, and then you're taking another breath too soon. You're not really breathing adequately. Okay, so the next stuff that we're going to talk about is how to assess the cardiovascular system. Okay, when a chief complaint is chest pain or discomfort, check for any abnormalities in their cardiovascular or chest region. This also includes assessing, remember, the abdomen and the respiratory system. So you're going to listen for breath sounds. You can listen to heart tones too. It's a very difficult thing to do, but there are some things that we can ascertain from heart sounds, and it's kind of an advanced, more an advanced clinician's tool. But you are going to look at the chest. You are going to note any intercostal retractions, the skin kind of coming in between the ribs. You're going to look for ecchymosis and bruising, contusions, any abrasions, any seatbelt injuries that you're going to see if they're in a traumatic mechanism. You're going to look at their jugular veins up in their neck. If they're sitting upright, they really shouldn't have any distension there. You're going to look to make sure or you're going to palpate their radial pulses and make sure that they're the same on both sides. And the rates that we have between adults, normal for adults is 60 to 100. So tachycardia is over 100 beats a minute, and bradycardia is less than 60 beats a minute. Pulse quality that we've talked about already, strong pulse or bounding, that's just bounding hard against your fingers. A weak or thready pulse, if somebody has a very low blood pressure and they're already vasoconstricting from their hands and feet, you're going to feel a thready pulse. The pulse rhythm, whether that pulse rate is regular or irregular, and you can have a irregularity. So this is just going to be all over the place. Or you could have a pattern of irregularity. It just depends on what their heart is doing. Part of the cardiovascular system includes our vasculature and how our heart is beating. So what our blood pressure is, it's important to do a blood pressure measurement, and that manual blood pressure is important. So we're going to get a good blood pressure on them. So what can a decreased blood pressure indicate? It could indicate hemorrhagic or a loss of fluid or plasma. It could indicate that our vascular tone, so normally our vessels are just slightly constricted, and our brain kind of tells our vessels to do that. If we have a serious head injury or a spinal cord injury, it could disrupt that. And so all of a sudden it goes vasodilates, and then we have the same amount of fluid in a very large vessel. Our blood pressure is going to go down. So their blood pressure could drop. It could mean their pump is just not pumping right, that they've had a massive heart attack, or they have so much congestive heart failure that they're just unable to do that. It could mean they took too much of a beta blocker or a medication for their heart or their hypertension, and now they can't keep their blood pressure up. Um, in shock, blood pressures will fall. Um, our systolic will fall, and we need to assess whether they are in shock. We've kind of talked about what a systolic and diastolic pressure means, but that systolic pressure is the pressure that's caused along that the artery on each contraction or systole of the ventricles. So it's that pulse wave that goes through that artery. And the diastolic pressure is the pressure that is remaining in the artery when the heart or ventricle is relaxed. That diastolic pressure is actually pretty important. If it's too high, your heart is having to pump against a high pressure, and it can cause the growth of your heart muscle, that ventricle, to increase and can cause some congestive heart failure due to cardiomegaly or increased muscle mass. Our blood pressure is measured in millimeters of mercury. It's measured by a sphygmomanometer, and a auscultated blood pressure is a stethoscope is used. A palpated blood pressure, your fingers are used to palpate that. So don't forget to just keep taking blood pressures over and over again so that you're very confident in your ability to obtain blood pressures. We have talked about different sizes of blood pressures, cuffs. Those larger adults, they're going to need a larger blood pressure cuff to come around that arm because it needs to be an accurate blood pressure. So there are cuffs of different sizes. Hypotension is a blood pressure lower than normal, and hypertension is a blood pressure higher than normal. Our normal blood pressures are between 110 and over 70, 120 over 80 kind of thing. So anything much higher or lower than those go into those categories. Okay, our neurologic system, our brain and spinal cord, are fairly important to us. So any changes in our brain function or our motor sensory can cause some pretty devastating long-term effects. So it's a fairly in-depth thing to do a full neurological exam. And as we go into our body systems and talk about strokes and head injuries and things, I'll give you more on how to go into more of a detailed neurological exam, checking the cranial nerves and checking for stroke signs and that sort of thing. But right now, we're just going to talk about evaluating people's level of consciousness, checking their orientation, whether they know who they are, person, place, where they are, time, what day is it, or what month we're in, what year we're in, and events, what's going on. Do they know that stuff, or are they kind of altered? If they say can't remember the date, I usually, if they're an older person, I usually ask those around, if that is normal for them. When somebody is in a nursing home or something, they tend to lose track of time. It's not like they have, a job to kind of keep them in check. This is the weekday, I'm at my job, it's Tuesday today, so it is easy to lose track of time a little bit. And some of the more clarifying questions that we ask for orientation are things like, how many dimes in a dollar? If they can figure that out, that's a good indicator that something is working. A lot of people ask who the president is. I do not like to ask that question. I don't want to hear their political views. I don't care. So I tend to ask more questions like, who is this person that's sitting next to you? Or, you know, how many dimes in a dollar? How many quarters in a dollar? Um, what is this object that I'm holding up? That sort of thing. I don't care who the president is, and I don't care that they tell me their political tendencies. I really don't. So I hate that question. Just saying. You're gonna hear a lot of people ask it, and it just grates on me. Okay, so our neurological exam also includes our hands and feet, and if we can feel things, if we can grip things, if we have a strong motor response, if we can move our feet, if we can feel touch, and any problems with our circulation, motor, or sensory, it is important to understand that that's a big deal and it scares people. Also included in our neurological exam is pupillary assessment. So we've talked about the AVPU scale, we've talked about the Glasgow Coma scale, we've talked about orientation questions. We are also looking and inspecting the head and the face and the pupils. Anything in their ears that is coming out. It could be blood, it could be CSF fluid, cerebrospinal fluid. That will indicate a pretty severe head injury. So we're looking behind their ears for ecchymosis or bruising. We're looking around their eyes for any bruising. We're looking in their eyes for the whites. The sclera of their eyes need to be white. It shouldn't be red. It shouldn't be yellow. It shouldn't, be any color but white. So all that stuff is part of our neurological assessment. Hey, talking about pupils, they're normally round and equal, and they briskly respond to light and darkness. And so with a pen light, we can assess whether they are moving with the same speed and moving the same way. If it is bright outside, it is very difficult to shine a flashlight in someone's eyes and have them react because they're already constricted down if it's bright. So I tend to kind of wait for that pupillary response. I kind of shade their eye and move it. I don't have to use a pen light, so I'm doing the opposite. So instead of introducing light, I'm introducing darkness and looking for that. When I get into the ambient, it's a little bit easier to regulate the amount of light that's coming through, so it's easier to do a pen light response. And they should be moving. It shouldn't be just dilated and not moving, dilated and fixed, because if they are, it could be that you're doing CPR on them and their pupillary response is not working anymore because they're that dead. So that's important to note as well. Speaking of Perla, in your book, it uses pupils equal and round, regular in size, and react to light. In the advanced book, it uses Perla, pupils equals round, reactive, light, and accommodation. We usually don't test accommodation. Accommodation is being able to focus on something or the reflex of focusing on a near object, and your lens is kind of changing shape and then focusing on something in the distance, and that your eye is automatically going to, reflexively change so that you can keep that in focus. So I don't typically test accommodation, so it's okay to do pupils equal, round, and reactive to light, Perla. Let me write this. Pupils equal. So pupils equal and round, reactive to light is kind of how I do it. I don't test accommodation normally, so I don't have them focus on something, watch their pupil as they focus on something far and near to see that it's changing. But they should be equal and round. They should react to light. So they're there you have your pupillary responses. Okay, this is the inspection palpation of the head, the neck, the spine, which we've talked about when we went over the psychomotor part of doing an assessment. This is your DCAT BTLS. You're also taking more of a look. You're inspecting around the eyes for bruising, behind the ears for bruising, the fluid coming out of their ears, if it's blood or CSF or both. Just check for face for rash and petechiae. Petechiae is a like when there's minor broken capillaries, so it's like a red or purple spotting on the skin that you'll see increased pressure or something. You'll see that petechial coloring, or kind of like ecchymosis, I guess, but ecchymosis is larger. So you're just taking a more thorough, detailed approach to assessing the head, the face, the neck, anterior neck, posterior neck, checking for jugular venous distension, tracheal, making sure it's midline, and all the little tiny bones and areas. When you're assessing the eyes, you need to look at the color of the white, the sclera, which we've talked about. You need to check the pupillary response and how they are, and make sure that there might not be foreign objects in the eye. Don't rub them. You're checking for the mucosa, so the pink lining under the eye, bruising behind the ears. That would be the mastoids back there being discolored from bruising. Could mean a basilar skull fracture or a fracture, head injury from the base of the skull. That discoloration or ecchymosis behind the ears, that's called battle sign. And then around the eyes can also mean that they have some sort of basilar skull fracture. The CSF fluid coming from the nose, the ears, the mouth. Odors, whether they have what's called a fruity or acetone odor from their breath, meaning they might have increased glucose levels, or alcohol, or any sort of weird odor. Okay, we're just reviewing the inspection and palpation of the chest, looking for the intercostal retractions, a paradoxical motion, auscultating those breath sounds, looking for ecchymosis, DCAT, BTLS, all of those crepitus, grating sounds from the bones. The abdomen, we're going to palpate all four quadrants, looking for and palpating for rigidity, looking for distension. We're looking for any bruising patterns or ecchymosis. When you palpate someone's abdomen, they could guard, meaning they have a kind of an involuntary muscle contraction when you palpate, because they're tender. Could be something causing an infection in their peritoneum. Also, their flank area on the sides and back could mean blood collecting in the retroperitoneal spaces. More things that you're assessing in the abdomen, whether it is kind of bulging in different or distended in different parts. So the asymmetry could be their liver is really, swollen, severe distension, ascites where they have fluid gathering in their abdominal space, rebound tenderness. You probably heard when you possibly could have maybe appendicitis or something going on. You'll push down when you're checking the abdominal tenderness. It doesn't really hurt when you push in, it hurts more when you release that. So they'll kind of grimace more when you release that pressure. That's a rebound tenderness. With the pelvis, when you're palpating, remember you're going to push inward first on the iliac crest. If you have pain, you're not going to want to push down on those iliac crests because you could break that pelvis in more places. And also checking crepitus on the pubis symphysis there. All right, so most medical patients don't need their pelvis or genitals inspected, although it is important to note if they're urinating, blood or having a vaginal discharge for females. So you ask that. If they're unresponsive, you're going to have to check and then just cover them back up. DCAP, BTLS, crepitus, and motor and sensory function in each extremity, lower and upper. Remember to check bilateral pulses and movement. So in your skill sheet, you'll notice that you have pulse, motor, and sensory. If you don't get all three of those in the extremities, you don't get those points when you're doing your assessment. So just remember there's three parts: pulse, motor, sensory. Posteriorly, you're going to ensure that there's no decap BTLS. You're going to assess for that, any step-offs in the spine, any deformities, any crepitus, and look for any open wounds back there, especially in penetrating trauma. You're going to want to see if there's any more wounds that you're missing just by looking at the anterior. We've got a posterior part of us too. Now, we've talked about our reassessment survey being performed every 5 or 15 minutes based on your patient's stability. You should reassess your level of consciousness, your airway, basically your primary survey. So level of consciousness, airway, breathing, circulation, any skin sign changes, all of their vitals that you've assessed, and any of your interventions that you have done. So if they've taken a hit off of their metered dose inhaler, if they're having a respiratory issue, reassess their lung sounds to see if they're getting better. If their blood pressure was low, is it doing better? If their heart rate was high, is it doing better? And so this reassessment survey is performed just to see if I have any changes in my patient status. Do I need to reevaluate something more in more detail? Do they have a chest injury? I'm going to reassess lung sounds. I'm going to reassess and repalpate their abdomen if they have an abdominal issue. If I've splinted somebody, I'm going to reassess their pulse, motor, sensory distal to that splint, just to make sure everything is functioning as it should. So this reassessment survey every 5 or 15 minutes. It's your LOC, ABCs, and all of your vitals and all of your interventions. Now, to compare those baseline vitals, you'll need 2 or 3 if you have at least 2, if not 3 or more vitals. Trends happen if you've got 3 blood pressure, 3 sets of vitals, you can kind of see a trend. Just with 2, a comparison's not really very good. But if you're taking your vitals every 5 minutes, then you should have enough to trend and see if it's going up or down or getting better or getting worse. Reassess their chief complaint. So if they're having chest pain, reassess. So is anything that we've done helping? Is that pain still a 6 out of 10? Is it getting better? Is it getting worse? Is anything else happening? Are you nauseous now, whereas you weren't before? Are there skin signs changing? So you can kind of see what is happening, whether say you were not going code 3 to the um, hospital because you didn't identify a big life threat, something that doesn't need to get there fast. And when you reassess, things are getting worse. Maybe you need to upgrade to code 3. So you can change your transport decision at any time. Rechecking your interventions and reevaluating what you've done. Do I need to do more? Is what I've been doing the right thing? Um, Managing any wounds. Are they bleeding still? Do I need to apply something else, another dressing? Do I need to loosen it because it's cut off all circulation? All those kind of things you're reassessing. And last but not least, just a reminder what I've been saying. Identify and treat changes in your patient's condition. So if they're worsening, maybe upgrade. If they're getting better, that's great. Any change in the patient's condition based on the interventions that you've been performing needs to be documented. And again, we are going to reassess the unstable patient every 5 minutes and the stable patients every 15 or so. So that is your patient assessment in a nutshell. And the more that we get to practice this stuff, the better at it you will be. Medical assessments take a while to learn the questioning, the questions, the questioning techniques that you're going to be using. So we'll start practicing those as well as the trauma assessments. Do you have any questions? If you do, please write them down, bring them to class. I know this was a long chapter, and I appreciate your patience in listening to this. Have a good day.